special needs. We're going to do musculoskeletal, and birds will be incorporated into that. Please don't forget about the quiz. Opened up now, Tuesday, and it will be available until Thursday night. Let's put it that way so it doesn't confuse anybody. So you want to get to it by Thursday night. The other thing is, it's on last week's lecture only, which is GI and neuro. Okay, that content only. So, it's a pediatric client with special needs. What do we mean when we say a client has special needs? What we basically mean by that is that this is a client who has some sort of medical, physical, psychological need on top of just the regular needs. And usually these children are actually mainstreamed into the regular school system at this point. And this all came about with a lot of these legal issues and public laws that came about. In fact, the first number there, like that 94, 99, that was the year those laws came into effect. So for example, having an individualized education plan, which is what an IEP is something that helped to, it was actually a group of, usually what that means is that you have a group of school providers, teachers, the school nurse, school psychologists, social workers, guidance counselors at the school that come together and set up an individualized education plan that's tailored to that child so that they are able to learn in that school environment, basically be mainstreamed there. And this is, even like with the later laws in 99, this was really trying to put into effect that as soon as a child is seen to have any kind of special needs, they should start to be under social services and special services, not DIFAS services, but support services in the community that are available. Because they do find that patients that get earlier help, earlier interventions, especially in terms of learning, do better overall with their outcomes. Head Start was a program set up for preschoolers with special needs. And some of those special needs even being those that might be of lower socioeconomic status to help them. So these are the things obviously you want to assess whenever you come across a child who might have some special needs issues, something that sets them apart. These are the kind of things you want to look at in your assessment. And the first one we're going to talk about in particular is cerebral palsy. Has anyone ever seen this? Know patients with this? Know anything about it? Okay. As she's walking in.
This is good timing, right?
Yes. Thank you.
One of my coworkers, her son has cerebral palsy.
Okay. And how does he look?
How does he look?
Or what are his needs? Does he have? What are his special?
He has growth motor issues. He uses canes to walk, and then he has like an electric wheelchair. He doesn't have, he's a little slow, but not I don't know how to describe where his mental. I don't know what you would consider. He is an adult. He's a little bit slow, even just talking and stuff like that.
Okay, slurred speech. They do say that most children with cerebral palsy actually have very high IQs or normal IQs. Sometimes it's not the IQ so much that's affected. The speech is affected and the gross motor is affected. And that's why what you're saying does match, with cerebral palsy. And there's a range of their abilities. You going to say something, Dean?
My nephew has cerebral palsy. His eyes are crossed from his mouth, and when he cries, his left lip falls, right? And his tongue would fall to the side. He's very, very smart, above average intelligence, super smart, and he normally walks and drags his feet are weak, he drags his feet a little bit, but now he walks with crutches, they move.
Yes.
He uses that, right? He's more stronger in his upper arms than his lower legs, and he slurs a little bit. Yeah. And he also wears glasses, maybe to correct the cross-eyed.
But both of these situations do sound very high functioning too. Because there is a range, as I mentioned, and this is kind of like one of those spectrum disorders in which there are people with this diagnosis who are bedridden, who cannot move at all. They have severe contractures, and it is gross motor. So some just have some slurred speech, and ataxic gait and some minor contractures, and some are very severe, cannot speak, have aphasia because they can't, the motor functioning for them being able to speak is affected. Yep, so there's many ranges in what you can see, but it's all gross motor for the most part.
Actually, I have a friend I went to high school with,
Mhm.
and, when she was in high school, she used either like a walker or an electric wheelchair. Her mother helped her tremendously with the writing. She couldn't really write. Her speech was definitely like sort, but also very intelligent. She went to Barnard. She went to like an Ivy League college.
Yeah. Usually intelligence is not the issue. Very rarely, they say, is intelligence the issue. I think it's 1/4 of the cases intelligence is affected. For the most part, it's all the gross motor.
Actually, I don't know now.
Yeah.
Just recently, I think last year, she had some kind of spinal surgery, which I guess she
Very
got
common.
from weakness. And she's doing well. She lives on her own.
Right.
Still in a wheelchair, and some of these tough people just keep going.
Yes, and you brought up, Melissa, you brought up a very good point. The parents in all of these diagnoses play such a key role. In all of them that we're going to talk about today with special needs, the parents are very key. I always tell students, when you have a patient with special needs, talk to the parents. They're going to be your greatest resource. They're going to be able to help guide you in how to take care of this child. Because there are a range of what you're going to see, especially when we get to autism and we talk about things like that. Again, another spectrum disorder and a range of what you would see. So you want to say to the parents, how should I approach your child? What can they do? Because you don't know their abilities, their limitations, these kind of diagnoses until you spend some time with them. And the parents are a great resource. I attended a conference a couple of years ago down in Maryland, and one of the mothers who was a nurse practitioner was talking about her son who had autism. And she said that, only twice in all of his hospitalizations had a healthcare provider come in and said to her, is there a better way for me to approach your son if I have to take his blood pressure? Or is there a better way for me to approach him if I have to take his temperature? Which she said was great because most people would just come up and start to touch him and grab him and do the things they needed to do, and he wouldn't respond well to people touching him. It was all about the tactile stimulation he didn't want. So again, parents are a great resource here. Unfortunately, they often become the lifelong caregivers for some of these patients too, which puts a lot of burden on them when we talk about caregiver stress.
And I would imagine the outcomes are affected greatly by what kind of parents.
That's absolutely right. The outcomes are definitely affected by the support you have, and the number one support component in all the research is being the parents, and that's the initial family support. Sometimes, unfortunately, parents are not strong enough, or families are not strong enough to deal with this sort of diagnosis, and then these children end up with foster care, which unfortunately too is not as supportive. So that's the downside. It's very sad. So when we talk about the best outcomes, it really has to do with the family support, and then the support that they get around them from the community, social workers, community services. You can say something?
Doesn't Stephen Hawking have cerebral palsy? Is that what
No.
he does?
I'm not sure what
He has Lou Gehrig's.
Oh,
He has Lou Gehrig's.
Yeah,
He was totally
I
fine.
know, yeah, exactly. I know him, I know who he is, I'm not sure what caused him to be.
He has Lou Gehrig's.
Yeah, he's.
That's why he talks like that. He has like a thing set up. It follows his eye movement, and that's how he talks.
Yeah. And again, cerebral palsy is something that you have a normal pregnancy, usually, normal fetus, and then something happens either in the pregnancy, toward the end, or even during the labor process. Like some of these cases I've seen have been like twin births or multiple births, where one of the children actually, had a period of anoxia. The other one was born maybe, but one, so you can literally have like two twins where one has cerebral palsy and the other does not, because it really has to do with a period of anoxia, either during the labor process prior to birth, somewhere around there. And what happens is, because that period of anoxia, so close to the birth process, there's gross motor abilities that are affected. It affects the gross motor ganglions and the neuron system. So what happens is you get these delays with speech, you get problems, again, ranging with gross motor ability. And again, it is a definite range in what you can see.
I asked my coworker about it because in the book, a lot of the stuff that we already looked at last week for neuro
Right.
goes
with
with
this.
cerebral palsy. And I asked her if he had anything else besides cerebral palsy because of the birth. She said no.
Yeah.
That he's unlikely that you would have nothing else, but he doesn't have anything else.
And that's a great prognosis too. Again, what people will say, what's the prognosis? It really has to do with comorbidities. So again, when we talk about, like, for example, increased ICP, having hydrocephalus is very common in children with cerebral palsy. What you talked about, Melissa, is very common because over time, the contractures will become more and more progressive. Not so much, the disease does not progress. I want to be clear, the disease itself doesn't, but contractures can, and that can actually cause more kyphosis. And many times these children often have to, or as adults, they often have to have spinal surgery. Harrington rods to help straighten up, which we'll talk about later in this lecture, to help to straighten up because there can be severe kyphosis, which can cause problems with breathing, respiratory issues, so that's why sometimes they need surgery too. So the goal is early recognition, intervention. There's different classifications, which the most common is mixed. And a lot of times this has to do with the muscular movements that you see with these, spastic, ataxic, but most are actually a combination. And again, one of the common nursing diagnoses is the impaired physical mobility. And how impaired their physical mobility is will determine how severe or how good their prognosis is. Okay, if they're very severe and they're very limited in their physical mobility, their prognosis is much worse. Because obviously, they can even have issues breathing on their own. And over time, they can develop decubiti. Again, going back to what is their support system? Is it somebody who's able to turn them every hour? Somebody who's able to clean them properly if they're not able to be continent? So all these sort of things that come into play will help to build your prognosis for these patients. And again, lifelong. Many times it's a worry for the parents on how these children are actually going to, how they're actually going to survive after the parents are gone. So it's definitely a worry, and that's why they often have group homes or even community living settings for people with some of these diagnoses like Down syndrome or cerebral palsy. But many can live and do very well on their own too.